Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We're going to be listening to retinal pathology to retinal practice with Dr. Jessica Steen, who is our speaker tonight. It's a special opportunity and honor for me to be able to introduce her. She's an assistant professor at Nova Southeastern University's College of Optometry, where she serves as an attending optometric physician, instructs ocular pharmacology and glaucoma. She's chief of the glaucoma service. She's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, and a fellow of the Optometric Glaucoma Society, and serves as secretary of the Palm Beach County Optometric Association, having served as president there. Now, fortunately, I have had a great opportunity to work with her. She was my resident several years ago, and it's really especially gratifying to see a situation where the student does surpass the teacher. I would not hesitate to say it is my firm belief she has surpassed anything I've taught her, has forged her own path, is one of the best speakers and minds in optometry, and we are in good hands with Jessica Steen. So Jess, please take it away.
Joe, thank you. Greg, thank you. And for everybody at home, thank you for spending your Tuesday evening with us and with me. Tonight, we're talking retinal pathology and real current trends in treatment and management of retinal pathology. This is one of our newer buildings on campus at Nova Southeastern University, the Center for Collaborative Research. And this is between our office building and where our parking garage is. So walking in or past this building every day, it's that reminder to say within an optometric space, within an optometric retina space, the importance of collaborating with not just primary care medicine, but with often endocrinology, internal medicine, neurology, as we're thinking about our retina patients, certainly, and then within our retina subspecialty care. So we're going to bring this together tonight. We're going to talk about this from an optometric perspective, but also what trends we see our retinal surgical colleagues employing, and maybe some of these observations you've had in practice, or to help also you to understand the considerations of your retina specialist when you are referring a patient for a second opinion or for treatment. My financial disclosures are here. Any and all relevant relationships have been carefully mitigated. So if we really start from a background approach, I think something that is always important to reflect on are where these major landmarks are in cross-section on OCT. Yes, we look at our patients clinically carefully, but when we identify pathology, really OCT is the backbone of ancillary testing in retinal care. And what I find is that sometimes it can be tricky to differentiate or discern, especially outer retinal features and landmarks. Keep this in mind, how you differentiate the external limiting membrane from the ellipsoid zone, made up of dense mitochondria within photoreceptors, from the RPE. These are often the three layers that can be trickiest, especially when there's pathology involved. Now, not to say that you need to memorize where each layer is and what it looks like, but in the case of uncertain retinal pathology, once you've done an OCT through, for example, that lesion, if it's not in the center of the fovea, and you find or you discern where exactly that pathology is located, that helps you to narrow down your differential diagnosis significantly. So these important landmarks, not just anterior, but I will say currently, really, I think the trickiest are to delineate the normal landmarks of the outer retina that are often very important in especially retinal vascular disease. So we know that retinal vasculature and the choroidal vasculature delivers oxygen to the retinal tissue. Now, where this is important is to think about the basis as to when things go wrong. How does this look clinically? And what treatment options are employed to restore or to attempt to restore this homeostasis? So that inner blood retinal barrier, what keeps blood, serum, and lipid inside the retinal vasculature, are the vascular endothelial cells, the tight junctions formed by endothelial cells and parasites. Now, the outer blood retinal barrier, keeping what lives in the choroidal vasculature outside of the neurosensory retina, that's the RPE tight junctions that, again, to ensure to form that strong barrier in the state of health that can be broken down in retinal pathology that leads to whether that is blood, new vessel formation, or fluid that is able to enter the neurosensory retina either through the retinal vasculature, through loss of the inner blood retinal barrier, or by way of the choroid passing through Bruch's membrane and the RPE into the outer neurosensory retina. Now, there are two major retinal capillary plexi that we were never able to delineate or discern until OCT angiography. Fluorescein angiography was not able to differentiate this superficial capillary plexus, which primarily lives in the ganglion cell layer and a little bit in the retinal nerve fiber layer. We find that this superficial capillary plexus is most impacted in arterial-based conditions. For example, hypertensive retinopathy. Now, this deep capillary plexus that lives at the level of the inner nuclear layer, sometimes it's described as a prevenular capillary network. This is the capillary plexus that is primarily impacted in venous congestive retinal conditions like retinal vascular occlusion or diabetic retinopathy. Now, there can be impact to the superficial capillary plexus, which sometimes is secondary to this impact of the deep capillary plexus. Now, we've talked briefly about the RPE, and really the most current thinking about this outer blood retinal barrier is the RPE not just forming tight junctions with the cells surrounding each RPE cell, but also thinking about this complex as a living, adapting, adjusting, true three-layer model composed of the RPE cell bodies, the outer layer of the RPE, and remaining layers of Bruch's membrane. So again, if we think about retinal pathology, where is this detachment? What layer? Okay, can we find the number one, the external limiting membrane, the ellipsoid zone? So this is the RPE. This is a serous, again, RPE detachment. Now, moving deeper into the choriocapillaris, which is fed by branches of the posterior ciliary artery, and we know that the choriocapillaris follows this compartmentalized blood supply, which can impact the pathology that we see. A window defect, as an example, what does that look like clinically? Well, an area of focal RPE loss. So we are visualizing clinically right through, essentially to the choroid, through the neurosensory retina, through the choroid, due to focal absence or damage to the RPE. Not scarring or hyperplasia, but more dropout as a light appearing change in the retina. So how does this happen? Well, one of the ways that a window defect can clinically develop is because of this compartmentalized blood supply. Focal ischemia, again, instead of following a course of a vessel in the choriocapillaris, takes out a little punch lesion of the RPE Bruch's membrane, forming this specific type of window defect or clinical presentation. Again, truly a reminder is the normal state of anatomy and physiology and what happens in pathophysiology in disease states that are prevalent or that exist within retinal pathology. Now, moving deeper, thinking about the choroid. Now, on OCT angiography, this is a way to visualize the structure of the choriocapillaris. On the left-hand side, this is red blood cells moving throughout the choroid and choriocapillaris in a normal fashion. On the right side of the screen, this is one of the most impressive true choroidal neovascular membranes that I've imaged structurally by OCTA. This happens to be a treatment-naive patient with a choroidal osteoma and very large, very well-developed choroidal neovascular membrane. Now, moving deeper into the choroidal vasculature, just the reminder, it's not just red blood cells that are passing through this tissue. Of course, there are nerves, there are pigmented cells like melanocytes, And because there are immune cells present within the choroidal vasculature, this represents a source in the context of inflammatory retinal disease. Now, this specific case, these images were taken by a past resident, Dr. Wu, gorgeous images with steering to really be able to visualize these punched out lesions in a female in her 30s. Now, this was a patient who was initially diagnosed with acute anterior uveitis, and it was determined with a dilated retinal examination that this wasn't isolated to the anterior chamber. There is retinal and choroidal involvement. Now, is this active? Again, there were cells in the vitreous, but these pigmented and atrophic chorioretinal scars, in this case, it doesn't look like there's any activity. This is where incorporation of true multimodal imaging can be valuable. Again, we are way outside of the center of the fovea, but when we utilize fundus autofluorescence, imaging fluorophores, so what do we see where those punched out lesions are? The dark areas tell us that there is no lipofuscin present in those lesions. Where should lipofuscin be present? Again, we have this nice, in most of the retina, this healthy background glow. Lipofuscin is a product of metabolism of photoreceptors. So naturally, as photoreceptors function, they produce lipofuscin, which is recycled very quickly in a healthy functioning outer retina. When there is RPE stress, that means that the cells are not able to recycle this lipofuscin as efficiently as possible. So what happens? There is a lipofuscin buildup. That's what we see as hyperautofluorescence, which indicate in this patient's case areas of activity. Now, I'm going to move back to the previous photo for just a moment and do your best. I cannot find these areas of hyperautofluorescence on that fundus photograph, and certainly not clinically. So this is an additional tool. We're looking really in this area. Do we see any region of anomalous or abnormal retinal or vascular tissue? But fundus autofluorescence shows us where there is RPE stress. So why are there these dark areas? Dark areas mean that there is no lipofuscin present. This means that the RPE is not functioning. There is zero lipofuscin. This is dead tissue. So this previously diagnosed acute anterior uveitis patient, a very astute finding by our previous resident, determined that this is number one, not just acute anterior uveitis, but there is active posterior segment inflammation. Now, the concept of OCT angiography, again, we are looking at structure of red blood cells within the retina and in the choriocapillaris. So what happens is that multiple scans are taken at the same location over a slight delay in time period. So if we've got multiple scans in the same location over a set period of time, what's different between each of those scans? Well, the RPE cells aren't moving, the photoreceptors aren't moving, the ganglion cells aren't moving, the retinal neurosensory structure is not moving, but what is? Red blood cells passing through retinal or choroidal vasculature. So everything that is the same in each one of those images is subtracted, and we are left with a map of movement. And what is moving? Red blood cells. So this is a structural map of moving red blood cells in the retina and in the choroid. It's not a replacement for fluorescein angiography. Fluorescein angiography provides us with pooling, with leakage information. This is true structure of where these vessels are present. And certainly OCT angiography is not a replacement for OCT, but an additional feature, and again, now we are all familiar that OCT angiography does have a separate CPT code. OCT angiography and OCT cannot be billed on the same day, but realistically, if you're performing OCT angiography, you are still going to be performing your cross-sectional OCT scans. Now, let's look at a couple of cases where OCT angiography, maybe has demonstrated above and beyond what we might expect. This was an individual with a previous diagnosis of intermediate stage dry age-related macular degeneration, but carefully, when we look at the B scan, we see a pocket of subretinal fluid that's present. So why is there subretinal fluid in dry AMD? This is our clue. This type of near double layer sign appearance, this is our clue that maybe there's choroidal neovascularization. Now that tiny little pocket of fluid that's present, if as we're performing OCT angiography, we see no breakthrough this Brooks membrane RPE complex into the neurosensory retina on our OCT superficial or deep plexus analysis. But what do we see when we move into the choriocapillaris? The actual structure of this macular neovascular membrane, this fine, small, lacy appearance. This is what's feeding the subretinal fluid. In more advanced cases, this is a large fibrovascular scar in a woman with neovascular AMD who had decided enough is enough. She had declined further injections and retinal consultation. This is someone who, unfortunately, if we see what the end stage of macular neovascularization can be, sometimes I'll say in this patient's case, this fibrovascular scar with significant fluid looks quite impressive in a cross-sectional OCT scan, and maybe a little disappointing on the OCT angiography image in comparison to that image right beside it of that tiny little lacy choroidal or macular neovascular membrane. Do keep in mind that it can be difficult for the device, regardless of the device you use, to segment the pathology perfectly when there is disease that's present. Now, here's an interesting case. This was an individual who was in his mid-50s, a Hispanic male in his mid-50s, who had a diagnosis of neovascular age-related macular degeneration, who had been receiving anti-VEGF injections for about 3 years without improvement to visual acuity. Acuity was consistently this 20/30, 20/40 range, and he had presented for a second opinion. So, does this individual have evidence of choroidal or macular neovascular membrane? Well, starting at the top, superficial capillary plexus, nothing that's broken through Brooks membrane or the Brooks membrane RPE complex. Deep capillary plexus. Well, how about the choriocapillaris? Well, there's kind of an irregular signal, but there's no lacy structure to a membrane that's present. What does this patient have? This thickened, irregular RPE with subretinal fluid. And if you look carefully, you can see these areas of photoreceptor almost clumping and swelling. This patient has a very thick choroid in the right and left eye. This is a rare condition, but something called uveal effusion syndrome. This is someone who will not have improvement with anti-VEGF therapy, as it's not a VEGF-mediated disease process. So again, this additional information as a second opinion. So what do we do in this patient's case? We suggested very gently that this patient seek now a third opinion or a second retinal specialty opinion with the information to the retina specialist of what we found with OCT angiography and the concern and high suspicion for uveal effusion syndrome. Now, where are we looking in the retina? Remember, these venous congestive conditions like retinal vascular occlusion and diabetic retinopathy really start at the level of the deep capillary plexus, even though there will eventually be impact to the more superficial retinal capillary plexus. What are some of the practical challenges with OCT angiography? Well, this may be considered an advantage or maybe a challenge. This is static structural information, and it is important to differentiate the data or information that we get from OCTA versus fluorescein angiography. With even the most advanced currently available commercial systems, we're fairly limited to the field of view that we have. And, as this is a platform that's based on motion contrast, motion artifacts are still a big deal. all available devices in the United States have significant, I'll say significant improvements have been made to their motion or eye tracking software to reduce the impact of these subtle or small saccades that patients may make as the scan is being performed. But any motion artifact can take away from the image quality. And as we have seen, sensitivity of detection in eyes with underlying pathology, which is who we're imaging, can be a challenge. So, polling question number 1 here, Greg. Which capillary plexus is most affected in these venous congestive conditions like retinal vein occlusion and in diabetic retinopathy? Is it superficial capillary plexus in the retinal nerve fiber layer and ganglion cell interplexiform layer? Is it that deeper capillary plexus? Is it something that lives in between those two? Or are we talking outside or posterior to the Brooks membrane RPE complex in the choriocapillaris?
Polling question is open. People are replying. Joe, are there any questions so far?
No, there's a comment that Jessica can address. Saskatchewan is known as the Gap. Why is that?
Oh, whoever had said that, that is very astute of you. The gap, meaning the gap between Alberta on the west side and Manitoba on the east. Basically, less happens in Saskatchewan than it does with our neighbors. If you've ever made a cross-country road trip, or you've thought about taking the train through the Rocky Mountains all the way across Canada, you will pass Saskatchewan in the middle of the night in total darkness. It's pretty flat, it's pretty quiet. That's why it's known as the Gap.
So I guess the Gap is not a charitable name, is it?
It is not, but when you're from Saskatchewan, or I'll even say from Regina, Saskatchewan, we take these comments and with a grain of salt.
Many, I think in politics derisively refer to our Midwest as the flyover states.
There you go.
Well, Jess, I was lucky enough to lecture in Saskatchewan. I think not only once, but twice. So
That was Saskatoon.
I think so. Yep, I think that's it. Yep.
We'll say the other city in Saskatchewan.
The other city. All right. I think I was there twice. All right. Here's your polling question results. Superficial capillary plexus was 16%. We have deep capillary plexus as the winner at 57%. Intermediate capillary plexus 14, and your choriocapillaris at 13. So your winner was deep and then evenly spaced with the other 3 answers.
Excellent.
And yes, I've also lectured in Saskatchewan. I enjoyed being there. The travel was great. I was very fortunate. The day I arrived, they mowed the runway.
Excellent. Good work on the results. The deep capillary plexus is really where we're thinking in this venous congestive condition. This is where the core of the pathology really is. There may be superficial capillary plexus involvement, but really that is secondary to this congestion that happens deeper in the retina. So, what can happen to the retina? What is the retina's response? How does it react to stress? There can be an exudative response. This is loss of, for example, the inner blood retinal barrier, which means that plasma and lipid leak into the retina. We see this as intraretinal edema and clinically hard exudate. There can be an ischemic response, so capillary dropout. When we see this capillary dropout, this is more superficial capillary plexus that is more prone to this early dropout that leads to hypoxia. This drives microaneurysm formation in the context of diabetic eye disease, worsens capillary dropout, and because of now this mismatched supply and demand of oxygen in the retina, drives new vessel formation. Now, these two processes can certainly and often do happen together. Let's look at diabetic retinopathy really as an end organ that truly is impacted, related, of course, to the systemic condition. Now, it's not just about hyperglycemia. when we talk about diabetic retinopathy. There is free radical formation, there is significant oxidative stress, there's a direct impact on the vasculature, there's disruption in autoregulation, and there is a component of inflammation that drives pathology. Again, we can start to think about where treatments may impact the disease process. And yes, steroids and anti-inflammatory agents do still play a role in the treatment of diabetic eye disease. So we understand that for patients who are diagnosed with type 2 diabetes mellitus, there is a high incidence of diabetic retinopathy at that time of diagnosis. So these individuals should have a dilated retinal examination at the time of diagnosis of their systemic condition, and in the absence of retinal pathology, every 12 months thereafter. Now, interesting, type 1 diabetes mellitus, we know, is truly a different disease process, and honestly, no matter how poorly controlled that individual is, there's typically no retinopathy that develops for at least the first 5 years following diagnosis. This has led to the evaluation recommendation to evaluate with a dilated retinal examination 5 years after the diagnosis of type 1 diabetes mellitus, or at age 10, whichever happens first, and in the absence of retinopathy, then once a year. Now, of course, we do hope that these are individuals that are in, especially as we're talking about a pediatric population, not always, but a significant proportion of individuals are still within a pediatric population. Hopefully, these are individuals that are already in your practices for their once-a-year comprehensive eye examination. Now, interesting, women who develop gestational diabetes mellitus are not at increased risk of increased development of diabetic retinopathy. So there's no specific dilated retinal examination recommendation during pregnancy for women who have gestational diabetes mellitus. But for women who are pregnant, who have existing diabetic retinopathy, during pregnancy, diabetic retinopathy often worsens. So what does this mean related to treatment? Well, there are some challenges, of course, when we think about traditional therapy, or even most common therapy in diabetic eye disease. Anti-VEGF comes to the top of the list. Pregnant women will not receive anti-VEGF injections. Now remember, we all have and we all need VEGF head to toe to support our vasculature. What happens with ischemic stress is that vascular endothelial growth factor is upregulated. Now, when we think about the underlying physiology, all right, a developing fetus has VEGF that needs to be present to develop their normal underlying vasculature. So an anti-VEGF injection in the mother certainly could have and has reasonable impact on that developing fetus. So no anti-VEGF in a pregnant woman due to the potential impact on the developing fetus. So what options are primarily considered in pregnant individuals who require treatment, for example, with proliferative diabetic retinopathy or center-involved macular edema with reduced visual acuity? Not anti-VEGF. So what are the options left on the table? Panretinal photocoagulation, focal or grid laser if appropriate, and intravitreal steroid or periocular steroid, which is, again, risk-benefit, certainly a much preferred risk-benefit profile for a pregnant individual. Now, if we look at the severity scale that we currently clinically use, this was published right at the bottom, 2003. We're now 23 years, my goodness, since the last overhaul of our diagnostic criteria for our severity for grading diabetic retinopathy. Now, one piece just as a reminder, as an update in 2003 from previous severity scales, the difference that may come up is what we call mild non-proliferative diabetic retinopathy, which by the 2003 criteria is microaneurysms only. As soon as a patient has an intraretinal hemorrhage or a cottonwool spot, this is someone who has moderate non-proliferative diabetic retinopathy. This is different from the modified Early-House criteria from 1981. So mild, based on our current international classification, means microaneurysms only. By the 1981 criteria, very mild non-proliferative diabetic retinopathy referred to microaneurysms only. Again, this is where standard fundus photographs were incorporated to compare your patient to the standard fundus photograph for grading related to diabetic retinopathy. Now, this is not used clinically, but this is still a scale that is utilized in clinical trials. So what's next? We need an update. Number one, as part of the Mary Tyler Moore Vision Initiative, one big core feature is the diabetic eye disease staging system update. Now, the Mary Tyler Moore Vision Initiative was founded in 2018 with this overarching lofty goal to end vision loss from diabetic eye disease. What I think is most interesting to us right now is the work that is being done to update the staging system. Now, they're looking at three overall reasons or three overall pieces to the puzzle that are important to keep in mind for diabetic eye disease. Yes, diabetic macular edema. Yes, vascular diabetic retinopathy, but they're also incorporating diabetic retinal neurodegeneration. So again, thinking about this neurovascular unit, ganglion cell potential early damage that can, and we do see what does happen in diabetic eye disease. What part of this goal is to help to develop a severity score. So again, a different type of grading scale, which may be valuable clinically, maybe to better advise or differently advise our patients of their individual risk of development of vision-threatening disease, for our retina specialists to help to guide treatment, and from a research perspective, to serve as specific regulatory endpoints. Now, we are not there yet. This is still under works. But again, when we look at the most recent severity or grading scale is being developed in 2003, we certainly understand that our understanding of the disease process, our ancillary tests and tools that we utilize to not just diagnose but manage diabetic eye disease have certainly changed and advanced over that 23-year period and do need to be reflected in this staging system update. So what do we have for imaging modalities? Color fundus photography absolutely is still an important piece. It really doesn't change your management, but excellent for documentation and for patient education. Fundus autofluorescence, well, few indications overall that truly alter management. However, in the case of intraocular inflammation, and certainly in our patients who have intermediate stage, I'll even say at that point, dry age-related macular degeneration, this is useful to start to look for areas that may be indicative of early geographic atrophy. Fluorescein angiography still used by our retina specialty colleagues, but really more as a wide field test to evaluate what's happening in the mid-periphery, especially in ischemic conditions, including diabetic eye disease. ICG, uncommon to encounter, but indocyanine green utilized for choroidal imaging. OCT is the core that certainly is most utilized for determining treatment, and OCT angiography, an important adjunct as structure related to vasculature. So if we think about this very simply in diabetic eye disease, well, the three main reasons that vision loss occurs is due to diabetic macular edema, due to proliferative diabetic retinopathy. Now, it's not the new vessels that lead to vision loss, but it is those new vessels that crawl within this fibrovascular network, and this fibrotic tissue contracts, leading to tractional retinal detachment and therefore vision loss, and macular ischemia. Now, good news is that we no longer use this clinically significant macular edema criteria as defined by the early treatment in diabetic retinopathy study. What do we use now? Think about this clinically. We look at this particular patient. We see intraretinal hemorrhage realistically in 4 quadrants. We see these large areas of intraretinal lipid in this circinate, circular type pattern that is surrounding the thickening. And where is the center of the fovea? Really right in the middle. Do we need OCT to tell us that there is diabetic macular edema present? This is realistically something that we can see clinically, and we can even, in a flat photograph, have a high suspicion of where it is. Now, for management over time, certainly OCT metrics, especially as treatment is employed, is necessary to determine the effect and improvement. So we think about this more. Is there diabetic macular edema present? Yes or no? And sometimes in these subtle cases, OCT can be helpful to aid in diagnosis. If you determine that there is diabetic macular edema present, this is where OCT can be valuable, and truly valuable from a diagnostic perspective and referral perspective. Is it center involved DME, meaning affecting that central 1 millimeter subfoveal zone? Or is this non-center involved DME? Yes, there's thickening, yes, there's lipid, but it's outside of the center of the fovea. Again, we can already start to think about what we might expect these particular patients' central visual acuity to be. In non-center involved diabetic macular edema, there is a perfectly intact, although a slightly blunted foveal contour. There's a perfectly intact ellipsoid zone and outer retina and neurosensory retina above it. This should be a 20/20 eye, unless, of course, there's media opacity. At the top, center-involved DME, these patients may present with excellent 20/20, 20/25 visual acuity, but may have reduction in their central acuity. What is another way? How do we figure out, is this center involved? Is this non-center involved? This is where, in addition to our cross-sectional OCT, that the macular cube scan can be valuable. This is where we have the overall topographic type of overlay, and what we're looking for is thickening of this central 1 millimeter zone. These are the ETDRS, this bullseye type of appearance and type of approach. Now, this patient has significant thickening that we see on topography, superior temporal to the center of the fovea in the right. And in the left, is it encroaching on the center of the fovea? She's 20/20 in both eyes. She has a slightly increased central thickness. That area is just starting to impact the center of her vision. But what do we do in the context of a 20/20 eye? We'll get back to thoughts about referral patterns and consideration about what your retina specialist may do as we are referring these patients. If you determine to refer a patient with excellent visual acuity with non-center involved diabetic macular edema, or even very subtle center involved diabetic macular edema with 20/20 or 20/25 vision. We often think about microaneurysms as really an early feature. But once a microaneurysm has developed, this is a sign that there is significant retinal ischemia that is leading to, again, damage to the endothelial cells that line the retinal vessels, that lead to loss of parasites and this outpouching. This is a sign of ischemia. This, again, microaneurysms thought of as an early sign, but this tells you that this patient is well on the path of ischemic disease, meaning hypoxia, driving forward, increasing vascular endothelial growth factor, which may drive new vessel formation that we see, unfortunately, in this patient with poor central visual acuity and proliferative diabetic retinopathy. Now, the third approach, or the third reason where visual acuity can reduce in diabetic eye disease, is related to macular ischemia. Now, these are the patients that clinically, maybe they're 20/30, maybe they're 20/40, that type of range without significant media opacity. And you look at the retina, you see a couple of intraretinal hemorrhages, but nothing in the center of the fovea. You run an OCT because what's the reason that the vision's down? Maybe like our early patient, there's maybe a blunted foveal contour, but there's no center involved diabetic macular edema. So why is the vision down? With chronic ischemia, this is where in diabetic eye disease, there will be dropout, especially in this superficial capillary plexus, resulting in this almost moth-eaten or irregular appearance. We see that nice, previously dense superficial capillary plexus has lost its density and is far more irregular and almost this ratty type of appearance. This is something that, again, macular ischemia can be tricky clinically, can be tricky with spectral domain OCT and cross-section, and really a value point related to OCT angiography. If we look at this as an end stage condition, now this is not someone with diabetic eye disease. This is a young individual in her late 20s with hypertension. This is truly ocular ischemic syndrome in this woman. Now, she had come in for a second opinion on her reduction in visual acuity in both eyes. Here's her left eye. She is 20/40. Why is this eye 20/40? Well, if we look at the superficial capillary plexus, it's just missing. It's absent. There are these new anomalous vessels, significant neovascularization, but there is no capillary plexus that's present. This is chronic ischemic stress with broad neovascularization. Here's her good eye, the 20/30 eye. Still, these stars highlighting the signal related to broad neovascularization that we can find, again, in her case on this side, in the superficial capillary plexus on OCT angiography with already areas of significant dropout. Oof. Now, what does this young lady, again, in her late 20s, look like clinically? Profound ischemia. Bilateral cotton wool spots. Look at the new vessel formation. Again, generally we talk about these new fine leaky blood vessels in neovascular disease. These are well-developed, unfortunately well-developed vessels. Desperately, this is the body trying to get blood and oxygen to the oxygen-stressed tissues. We think about this young lady not just from a visual perspective, but if this is what the vasculature is in the eye, what is her microvascular health of the kidneys? What is her microvascular health of the brain? We think about this holistically. Here's kind of an interesting piece. This is the same individual. This is her left eye, the more affected or more profoundly affected eye. On the right-hand side, over the optic nerve, look at these new vessels. We can manually segment the vasculature that we're interested in. And this is a very nice manual segmentation of the fine, lacy vessels that we more so expect in ischemic retinal pathology and neovascularization. So thinking along the lines of ischemia, we saw the significant cotton wool spot in the previous patient. Here's another example. And in cross-section, again, if we're looking at this as a white spot in the retina, what could it be? You know, our differential diagnosis of white spots is fairly large. Through cross-section, we can say, where does that white spot live? This is now in the nerve fiber layer. This is focal swelling of the axons, of ganglion cell axons, a blockage or disruption of axoplasmic flow, focal swelling. So technically, you know, it's not really an infarction, it's really swelling of the axons in the acute circumstance. Now, what about treatment in diabetic eye disease related to new vessel formation? Well, panretinal photocoagulation is really still considered the standard, gold standard approach. However, we have seen, of course, the overall efficacy of anti-VEGF agents leading to regression of neovascularization. Now, some challenges with panretinal photocoagulation. Early on, immediately after the procedure, in patients with diabetic eye disease, there can be a worsening in macular edema. There can also be significant constriction of the visual field as there is direct damage that is happening to the retinal tissue. These are patients that can also develop vitreous hemorrhage. So there are some, you know, not just short-term, but long-term functional challenges that are employed with panretinal photocoagulation. This patient with proliferative diabetic retinopathy, we see once again this proliferation, this fibrovascular tissue extending off of the optic nerve with subhyaloid hemorrhage, cotton wool spot. Again, other new vessels. And does this patient have diabetic macular edema? Well, we see exudate, we see lipid, and we see intraretinal hemorrhage in the parafoveal area. In this flat photograph, realistically, the answer is yes. I think also interesting to see in this patient's case, look at the superior arcade. This pocket of fibrovascular tissue is now starting to contract. This is now pulling on the neurosensory retina. You can really feel the three dimensions in this photograph with the shadow that's being cast. This is someone who, again, there is no active real detachment, but this is someone with active retinal traction that will lead to a tractional retinal detachment as that fibrotic tissue continues to contract. By OCT angiography, yes, we have profound new vessel formation and also look nasal to the optic disc. This is high quality imaging, but there are no capillaries present. There is significant capillary dropout, and the optic nerve is effectively hidden by this fibrovascular network. Just to toggle back, this patient clinically versus the structure of these new vessels that have developed. Now, if we look at this particular proliferative diabetic patient, we know that this person has had panretinal photocoagulation, but chronic ischemia, still active neovascularization, and what looks like in this fundus image, maybe is there a macular or lamellar hole? Well, by cross-section, again, was chronic edema. There is almost this schisis appearance with significant outer retinal loss. So we think about this patient and the potential for improvement in visual acuity. Well, number one, where is the ellipsoid zone? We've got our PE. Maybe there's a little external limiting membrane, but really we can't find these photoreceptors until we move outside of the center of the fovea. This patient, realistically, from a central acuity perspective, does not have a good visual prognosis. Here is the dense panretinal photocoagulation. Here is a case where an individual may have a constricted visual field based on panretinal photocoagulation that was performed. The trend that we see currently is much less aggressive PRP, so more gentle PRP that is supplemented with anti-VEGF injections. Now, it's been 10 years since the initial well-performed large-scale multi-center clinical trial that demonstrated that anti-VEGF, this happened to be ranibizumab, was non-inferior to panretinal photocoagulation for maintenance of acuity. There was less visual field damage, as we've seen why that can be, and fewer vitrectomies needed because there were fewer vitreous hemorrhages in the anti-VEGF group. But what about eyes lost to follow-up? So from a practical perspective, anti-VEGF alone is uncommon to encounter in patients who have proliferative diabetic retinopathy. Because remember, anti-VEGF treatment is temporary. So if that patient is lost to follow-up, if that patient misses a visit, effectively, there is no active suppression of vascular endothelial growth factor. Someone gets lost to follow-up, resurfaces 3, 4, 5 years later, which unfortunately we know is still not uncommon even in our practices. This is someone who, for eyes that only underwent anti-VEGF injections for proliferative eye disease, who were lost to follow-up, had worse visual acuity outcomes than those patients with panretinal photocoagulation, a permanent therapy. So this is what has formed the basis for the current treatment approach, which is generally very light, gentle PRP to try not to impact the peripheral functional vision as significantly, with frequent and ongoing anti-VEGF injections. So PRP, generally less aggressive than previous, but you may still see patients who have quite dense PRP, that these are individuals with constricted visual fields. Now, anything other than intravitreal injections in the diabetic eye disease space that is being explored? Well, one of the earliest that is still under investigation is an oral tablet. This is an agent that is proposed to reduce underlying vascular endothelial growth factor signaling and directly reduce inflammation. Now, this is an agent in clinical studies. I think it's important to think about these non-intravitreal or less invasive options as for us as optometrists, realistically, what might the goal of treatment be? Potentially to treat individuals earlier to reduce that patient's need for intravitreal injections, or for individuals who are receiving intravitreal injections, maybe supplementing with another mechanism of action and another route of administration to reduce the frequency of intravitreal injection. So again, this falls realistically firmly well within optometry's wheelhouse if and when there is an FDA approval for a non-injectable treatment in diabetic eye disease. So 3 under investigation currently. The second is another oral agent as an oral monotherapy for patients with diabetic macular edema with non-proliferative diabetic retinopathy. Patients were randomized to receive one of 3 doses or placebo over a 12-week period. I did have one patient who is enrolled in this clinical study. Of course, I don't know if she was in the treatment or placebo group. Ultimately, after the study ended, this was someone who did require intravitreal injections. And then maybe most of most interest to us as ODs is a topical ophthalmic agent. There is anticipated top-line clinical trial data anticipated in the second quarter of this year. Now, what is this topical therapy that is being investigated for diabetic macular edema? Well, it's a dexamethasone product. It is a proprietary dexamethasone suspension that is being investigated 6 times daily for 6 weeks, followed by 3 times daily for 52 weeks. So the idea of a topical ophthalmic agent, again, sounds wonderful, but we understand, again, from a glaucoma realm, even from a dry eye disease realm, that when we think about adherence to therapy, we understand that adherence is impacted by the number of treatments required per day. 6 drops for 6 weeks, followed by 3 times for a year. That is aggressive and frequent dosing. So again, I'm curious to see the overall phase 3 data that, again, we're anticipating in just a couple of months. However, we've had other topical ophthalmic agents under investigation that have been challenging. Again, what are the challenges in having penetration of an eye drop to impact retinal tissue? Realistically, more of a physical barrier exists in phakic patients, in pseudophakic patients with an intact posterior capsule. Generally easier for any agent to move its way to the posterior segment for pseudophakic patients versus phakic, and pseudophakic patients with an open posterior capsule. So 3 agents on the horizon, none of which are currently FDA approved. And
Hey,
what about eyes?
Jess, before you go on, just a quick question that came in from an attendee. Any worries, insight, or thoughts about systemic issues when using these oral medicines?
Great question. And this is something even outside of a diabetic eye disease space. But first, APX 3330, this is something that, again, it's an agent that had been developed for another disease state. What was seen even in early clinical studies is that GI upset was fairly common, and in high doses, rash and hives developed in individuals. So, when we think about this, again, it is something to remember that while we're talking about treatment of an ophthalmic condition, remember that this systemic ischemic stress, this vascular endothelial growth factor upregulation, realistically, in a patient with diabetes mellitus, is systemic in nature. So when we think about mode of treatment, yes, intravitreal or direct retinal targeting makes sense from a retinal disease space. But when we think about the disease state as a whole, is there another mechanism that can be helpful head to toe? Now, we do see other systemic therapies being investigated. Number one, in a geographic atrophy space. This is something that to me is a little bit more concerning as impacting the entire complement system head to toe. There are real potential safety considerations. This is a therapeutic in very early clinical studies. And, when we think about any direct retinal treatment, even anti-VEGF therapy, there is some systemic impact. And, you think about the proposed and sometimes controversial discussion, even with anti-VEGF agents, and the impact on risk of stroke or cardiovascular disease, including heart attack. So this was a conversation that was, really very early when anti-VEGF agents, intravitreal anti-VEGF agents were new. Still, generally, what will happen is before a retinal specialist injects a patient with an anti-VEGF agent, the nurse will generally measure the patient's blood pressure to determine, is this patient already at significant risk of heart attack or stroke, and the injection may be paused or delayed. So always thinking about not just with a systemic treatment on the whole body, but also thinking about the systemic impact of ophthalmic, specifically here, intravitreal injections. So what about eyes without diabetic macular edema? So these are patients that should have 20/20 acuity, right? There's no DME. Two well-controlled randomized clinical trials both determined that injecting with anti-VEGF treatments did reduce the grade of diabetic retinopathy. The retina looked better. There was a reduced risk of development of advanced diabetic eye disease. However, what is one of the most typical endpoints that is utilized and insurers also want to see, patients want to know, will it improve my vision? Well, if someone's 20/20 to start with, it's not directly possible to really measure an improvement in acuity. So then we go to what is the risk and potential benefit. Risks of anti-VEGF injections are low, but we understand the risk of infection. Of course, the risk of elevated intraocular pressure, the low but maybe not insignificant risk, especially in individuals with underlying systemic disease of cardiovascular complication. So risk versus benefit. What is the benefit? Well, less risk of development of advanced disease. This is why, in general, most of your retina specialists, and especially in our area, individuals, retina specialists will not inject 20/20 eyes without diabetic macular edema because of the lack of potential for improvement with the small but not zero risk of complication. There is the port delivery system that is now, once again, FDA cleared in individuals with diabetic macular edema, with diabetic retinopathy, and in individuals with neovascular AMD. This is a surgically placed reservoir that elutes ranibizumab that is refilled generally every 6 months in an office-based procedure. So, polling question number 2. What's a possible advantage of anti-VEGF over panretinal photocoagulation in patients with proliferative diabetic retinopathy? I always think about this as, if I'm the patient, what is an advantage? Do I want PRP? What am I concerned about with PRP? Is there a lower risk of severe vision loss in the anti-VEGF group? Is there better preservation of visual field in the anti-VEGF group? Does anti-VEGF reduce the need for follow-up care with retina? And is anti-VEGF cheaper than panretinal photocoagulation? One of those is accurate. Which one is it?
And you're all caught up on questions.
The poll is open. Answers are rolling in. I'll give it a minute or a few more seconds. I know I can do a minute, but a few more seconds. All right, I think we have the trend established. So we will display the answer. And we have 18% going with A. Your winner is 76% going with B, better preservation of visual field. And then we have 5% and 3% for C and D. So it goes 20, 72, 5, and 3.
Yes, great work. Thanks for staying with me. You're exactly on it. That anti-VEGF treatment, does preserve the visual field versus PRP. But again, from a practical perspective, what we see in clinic is often gentle PRP supplemented with anti-VEGF. So let's shift gears. Let's talk about age-related macular degeneration. So when we see a patient who has either an established diagnosis of AMD or someone that we're seeing for the first time that you have just diagnosed with, let's say, intermediate stage dry age-related macular degeneration, what's our goal after diagnosis? It is truly to identify those individuals who are at highest risk of disease progression. Who are those patients that we should be watching more closely? Who are the patients that really, maybe you're thinking, if you're using an Amsler grid, who are the patients that really should be using it monocular daily? Is there another tool that you consider that realistically has better sensitivity and specificity for detection of change that is not an Amsler grid that exists? How do we stratify these patients? So we're looking for high-risk features, and these are OCT-based features. The first to watch for are called subretinal drusenoid deposits, sometimes called reticular pseudodrusen. They really refer to the same finding. These are abnormal deposits anterior to the RPE. So once again, where's the RPE located? This bright hyperreflective line, I like this image at the bottom best. We see a flat RPE with this triangular protrusion anteriorly. That is the reticular pseudodrusen or subretinal drusenoid deposit. You will see these findings, these reticular pseudodrusen, in combination with the other hallmarks of age-related macular degeneration. And the bottom image, we see a very nice typical druse, that elevated RPE, so drusen under the RPE, versus and differentiate that from this high-risk feature for advanced progression to late-stage disease, which is geographic atrophy or neovascular AMD. Now, the other little clue is, those of you who are looking carefully, when you look at that reticular pseudodruse in the bottom image, look at the tail that follows down with it. This signal, this is OCT signal, this is telling us that there is sick RPE that's present because the OCT signal is able to pass through that sick, irregular, damaged RPE more easily versus the intact RPE beside it. So again, we're looking for these features. Sometimes you'll see the subretinal drusenoid deposits on this en face OCT image that has a much wider distribution. Maybe in cross section, you're scrolling through your OCT scans and you see a handful, 5, 10 reticular pseudodrusen. I do like to use this en face image. Sometimes you see that there is actually a lot more subretinal drusenoid deposits or reticular pseudodrusen that are truly present that can be imaged again by just it's our same OCT, but a different type of image. What else do we look for? Hyperreflective foci, this separation of RPE that moves anterior. So it's this breakdown of the RPE with pro-inflammatory cells, these isolated hyperreflective little pockets that are detached from RPE. What else do we look for? How much drusen is present? What is this relevant, I'll say, metric? Is 0.03 millimeters cubed. That's a volumetric area of drusen. Now, as we're scrolling through our B scans, you can really say, is this a lot or a little bit of drusen? Depending on the device that you use, many have an additional objective way to measure drusen area, measure drusen, in this case, volume, which is another metric, a quantitative metric that can be watched over time, especially as we're watching for progression. We also look for drusen that have this hyporeflective core, these calcific drusen. I will say they are the most tricky to see and fall lowest on my list. I'm scouring the scans for hyperreflective foci, reticular pseudodrusen, and I'm paying attention. Is there a heavy or a high drusen load? If you have availability of advanced metrics, 0.03 millimeters cubed is what you are looking for. Here is an 84-year-old woman. She has a history of bilateral rhegmatogenous retinal detachment. She had a buckle in the left, pneumatic retinopexy on the right, and has an established dry AMD diagnosis. With color fundus photography, the vision's reduced in the left eye more than in the right. We see RPE changes. Is there any geographic atrophy? Not that I can really tell in this image. We see the yellow overall drusen. We see the RPE hyperplastic change. In this case, the en-face image, not great quality, but once again, especially in this right eye, we see that there's a lot more activity superior to the center of the fovea than what we can see in the color fundus photograph. Now, scrolling through her OCT, starting again slightly superior to the center of the fovea, already in this scan, look at this tiny little pocket. Here's hyperreflective foci. We already have loss of, in this case, the ellipsoid zone and external limiting membrane and outer retina with this sinking in of retinal layers. Again, hyperreflective foci. Overall, we see this fairly significant drusen load. Look at the OCT signal passing through the sick, irregular, damaged RPE. And if we go to the left eye, starting superior, this is an excellent example of how reticular pseudodrusen presents. Number one, it's actually more common in women, as AMD is across the board, and it's more common to see outside of the center of the fovea. Reticular pseudodrusen follow the distribution of rods within the macular region. Traditional standard drusen tend to follow the distribution of cones, meaning more higher density in the central macular region. Reticular pseudodrusen more common outside of the center of the fovea, and statistically most common to find in the superior arcade, interestingly enough. Not just looking at the center of the fovea, one scan, we are scrolling through our device. All right, this large drusenoid, almost pigment epithelial detachment with hyperreflective foci. Again, sick irregular RPE and a very nice example of hyperreflective foci once again. We can watch this change over time. Now, this is not something that I do, but I did this once to prove to myself what happens to drusen as disease progresses. Here's a very run-of-the-mill drusen 2020. The same drusen 2023, its core starts to get lighter in color. Again, the signal of the OCT gets stronger passing below it, and it looks like there's subtle, again, hyperreflective foci. And by 2024, we have well-developed hyperreflective foci. That dark gray core, this is calcific drusen. This is disease progression, as evidenced even in this one tiny little realm. We know that this patient has high-risk features and is changing over time. This is someone that I'm watching at this point every 3 months. She is carefully self-assessing for visual change. This is an individual who has real risk factors for advanced disease progression. Depending on the tools that you use, you may have some other interesting metrics to watch for change or increased drusen load over time. Here's the metric that I mentioned as we're watching for drusen volume. Again, that key marker is 0.03 millimeters squared. And in this right eye, she's currently, again, at about 0.065 to 0.07. Now, something interesting. As we're watching this patient over time, the drusen load is increasing. It took a sudden increase in 2023. Now, moving to 2024, it starts to take this downward trend. Is that good? I worry about this, that this is maybe not stability, but maybe moving towards atrophy or geographic atrophy. A lot more irregularity in the left eye, and certainly we are well above that metric of 0.03 millimeters cubed. This is a woman who is at high risk for development of late-stage disease. Here's just another example of a very recent patient as a first-time patient to me. She knows she has dry age-related macular degeneration. She uses her Amsler grid. She takes her AREDS 2-like supplementation. Clinically, what do we see? Well, diffuse drusen, RPE changes. I wonder if there's some early atrophy in this right eye. Color fundus photography, not the best way to detect atrophy, but no evidence of blood. There's no clear hemorrhage. Her drusen volume is 0.04 millimeters cubed in the right and 0.06 millimeters cubed in the left. Already, we have a feature that this, unfortunately, for this 73-year-old woman, this is a woman who we are concerned about progression. Now, just to see what this looks like as we scroll through the OCT. So this is what I mean. Sitting at your device or at a workflow station, we're looking, hyperreflective foci. There are some reticular pseudodrusen that are present, but we are looking through the entirety of the scan. It's not just a single central image. We are looking for features across the board. So question number 3, based on this patient's findings, remember, this is a first-time patient to me in December of this year. When would you arrange for follow-up with, again, repeat imaging based on the risk factors that you've found based on OCT? So again, she has that drusen load of greater than 0.03 millimeters cubed. She has reticular pseudodrusen. She has hyperreflective foci. Is this an urgency? Are we seeing her back in 2 weeks from now? Maybe 3 months from now versus 6 months? Or is this a once-a-year patient that you are going to follow? Again, this is as you are able, as you are able to manage this patient, that you have the tools, the technology, and the comfort in managing this dry age-related macular degeneration patient. When are you seeing her back?
You're all caught up on
Polling.
questions.
Polling question is open and people are rolling in with answers.
Excellent. I think these are such practical cases. This is something that we see on a fairly regular basis in a primary care optometry setting. How do we counsel this patient? This is someone who I am discussing about the real potential over a 2-year period for progression of disease that can affect central vision. Now, this is someone who's independent. She's in her early 70s. And this is also someone that, as we're going to get into, is there any other way to potentially intervene in this patient's disease state that is not related to intravitreal injections at this point?
All right. Well, it looks like the trend is in, and we have a significant amount of people that have replied. So let's display the answer. And let's display the answer. There we go. Now it's displaying. We have 1% going for 2 weeks. The majority is 70% going for 3 months, 28% going 6 months, and 1% going a year. So 70% was the majority at 3 months.
Excellent. This is exactly, I followed your lead. 3 months in this patient with very careful counseling. That reminder, if something's not right, if you have a sudden change to your vision, don't wait to see if it gets better. Certainly come and see me on an emergent basis if you have any new concerns. This is something that, while this patient has high-risk features, we also do want to establish how quickly is she changing. This is where I would go to 3 months versus 6. Let's watch this patient. Let's understand her disease progression before we think about reducing the reins that we very well may not be able to do in this patient's case. So what could be considered? This is what I would consider high-risk intermediate stage AMD. This is a patient who would have met the criteria for enrollment in the LightSight 3 study that evaluated photobiomodulation. It included 100 patients. 2 eyes in some patients' case were enrolled in the clinical study, and over 2 years, patients were randomized to receive a specific protocol of photobiomodulation versus sham. What the thought process is this specific protocol, specific wavelengths and frequency of treatment, not dilated in an office environment, seems to increase mitochondrial function, to overall improve cellular processes. The primary endpoint in this study was improvement in visual acuity. That's not something that we think about in age-related macular degeneration. We generally think about slowing of worsening or slowing disease progression. Patients did have, on average, about a 1-line improvement, and the people who received active treatment had a decrease in new onset geographic atrophy. This is the device that exists. It is FDA cleared and available. Now, here's the real nitty-gritty points. Each session is about 5 minutes. In the clinical study, patients received 9 sessions over the first 3 to 5 weeks, and then every 4 months they were treated. This was a 2-year study. Here are the 3 wavelengths that were introduced, and the choice of these 3 wavelengths were directly with the goal of targeting nitric oxide, vascular endothelial growth factor, and electron transfer to support mitochondrial health. Now, some challenges related to this study. There was significant dropout. The study was performed during COVID, recruitment was challenging, and patients chose to leave the study. It's overall a small sample size, and practically speaking, if we are replicating or attempting to replicate the clinical trial environment in a practice, that means it's 27 visits per year for the patient with intermediate stage dry AMD. Now, patients in the treatment group had a 5-ish letter improvement. Patients in the sham group still had a 3-letter improvement. Now, something interesting was that most of the visual acuity improvement happened in the first month of the treatment. So is this, again, is this a perfectly objective way to measure visual function? No, visual acuity is a limitation here. Again, more structural imaging or objective functional imaging really is something that's being investigated. But we think about this. This is you, this is a family member. For someone with intermediate stage dry AMD, what do we tell our patients? We caution them, we identify high risk features, we talk truly, as Greg, really is, I think, the absolute icon of this, in talking about holistic approaches to overall nutrition and lifestyle. But what do? We essentially wait for these people to progress to need intravitreal injections of anti-VEGF, or if they develop GA, to try to slow it down. Is there a way to intervene earlier? Now, we do have a number of offices in South Florida who are utilizing this device. The cost profile has changed since availability. Initially, it was about $2,000 out of pocket, not covered by insurance at this point, for 1 year of treatment. Again, that's not the entire clinical trial period. I've seen some changes in that cost just based on overall patient demand, but it is something that I do offer patients who would meet the criteria. Again, limitations for our Medicare age individuals, cost and frequency of visit. Now, here's just one other piece as we're transitioning and thinking about neovascular disease. This is an 83-year-old white male who had reduction in central acuity in the left eye with a previous diagnosis, and this had gone back years, of chronic central serous chorioretinopathy. This is a red flag based on patient presentation, even though the clinical appearance here really does look quite similar to what you might expect in central serous chorioretinopathy. But look at this separation, this splitting of the Brooks membrane RPE complex. That's always suspicious as a double layer sign, that slang of split of the RPE and Brooks membrane below it, for something living within that space, which can be choroidal neovascularization. This individual has a large and well-developed choroidal neovascular membrane. He has neovascular AMD, not central serous chorioretinopathy, and he's done actually very well with intravitreal injections. So let's wrap up in thinking about pharmacology in retinal disease. We've talked a lot about vascular endothelial growth factor as a target. Now, we all need VEGF. It is an important signaling protein that is produced by many cells in the eyes and actually through the body as well. It is upregulated in response to ischemia. We all need VEGF. It's just when it gets upregulated that it leads to new vessel formation. Truly, this really is a first-line treatment for patients with exudative or new vessel formation in the United States. We have a number of FDA-approved options. The newest is the high dose of aflibercept, which is aflibercept 8 milligrams versus previous formation of aflibercept 2 milligrams, so 4 times the molar dosage. What's the goal in that 4 times molar dosage concentration? Well, the efficacy of our 2 milligram original aflibercept is excellent. The safety profile is excellent. So what's the goal in increasing the molar concentration? To have the same efficacy, overall similar or same safety profile, but with a longer duration of action. Now, the other agent that's a little bit different that I will say in our area tends to be our retina specialist's preference. Now, access and cost are always significant considerations, but faricimab has 2 mechanisms of action. Faricimab targets vascular endothelial growth factor A and another molecule called another signaling protein called angiopoietin 2. Now, Ang2 and VEGF seem to work in concert, that Ang2 can also, increasing Ang2, increases vascular permeability and increases inflammation. So it's 2 supportive mechanisms with the goal of more holistic treatment. It is FDA approved in the treatment of neovascular AMD, diabetic macular edema with a very low risk of occlusive vasculitis, not 0, but low risk. High dose of aflibercept, again, now on label in addition to neovascular AMD and diabetic macular edema for macular edema following retinal vascular occlusion. One of the practical challenges, why I will say in our area, is one of the reasons why we don't see this agent utilized as frequently, for example, as faricimab, is number 1, practicality. It is currently only available in the United States as not a pre-filled syringe, which means that the nurse needs to draw up and measure the medication from a vial for each dosage. When you are a very busy retinal practice, this is a disruption to patient flow. The other question about this overall aflibercept 8 milligram dosage is it is on label with specific dosing strategy. Now, we know our retina specialty colleagues will adjust the dosing interval based on what the patient needs, with the goal of increasing the amount of time between injections. Where we're at as these second generation anti-VEGF molecules like aflibercept 8 milligrams and faricimab is to extend the amount of time between treatments. Now, related to aflibercept 8 milligrams, there is a minimum on-label dosing frequency, or I'll say a maximum frequency of administration that is every 7 weeks. Now, what if a patient needs to be injected every 6 weeks for their neovascular AMD to keep a dry retina? Well, it would be considered off-label treatment, and coverage and cost become very challenging when we're talking about off-label retinal injection and retinal treatment. So this is another potential barrier, these guardrails on what is considered on-label. Again, realistically, these are patients that there is less room for flexibility and true individualized dosing based on the package insert. So cost and access, where are we? Heard today from a patient that her faricimab injection, her copay for the visit and injection is $200. And she was saying, is there anything else I can do? She has neovascular AMD and she has had an incredible result. She's been able to be extended to nearly 12 weeks. She's pushing 12 weeks between injections. And she's saying, is there anything else? The retina specialist, the answer from the retina specialist was, sure, there are lots of other options. that in your case may or may not be as efficacious, as successful, and certainly may need to be injected more frequently. But cost and access are still a consideration, a significant consideration. And we do still have access to bevacizumab, which is truly an affordable option. Many patients do respond very well to bevacizumab. What one of the challenges is the frequency of necessity of administration. If we're talking about neovascular AMD, that might be every 3 to 4 weeks versus one of these second generation agents with the goal of every 8, 10, 12, maybe even 16 weeks in certain cases. We know that patients in clinical trials related to anti-VEGF treatment in neovascular AMD have better visual outcomes than individuals do in a real world environment. What is the main reason for this? It's that people in clinical trials receive more frequent injections because of having this tight study-specific treatment. In real life, holiday, vacation, the inability to get to the office, a snowstorm, have to cancel an appointment, an illness, maybe the retina specialist canceling or changing a day of clinic due to a meeting or a personal reason. If ever there is a disruption or a missed visit, that delayed treatment can have an impact on visual acuity outcome. Now, very briefly, there has been news about this particular bevacizumab that is under investigation. Now, remember, bevacizumab that our retina specialists use as an anti-VEGF intravitreal agent is off-label for intraocular indications. Now, it's been well established as far as safety and efficacy over many years, and that's where it is commonly used. It is a cost-effective option, but there has been the push or the investigation for an on-label. That means developed with an indication for ocular conditions underway. It is currently approved in the EU and the UK, and it is undergoing FDA evaluation. Its first clinical study used dosing criteria based on a previous old ranibizumab study. These were patients with neovascular AMD that were either randomized to receive this study version of bevacizumab every 4 weeks. The comparator arm of the study were individuals that received ranibizumab 5 injections over a 12-month period. Now, we just talked about this. We know that patients in clinical studies do better than real-world environments in neovascular AMD because they get more frequent injections. So, if we're comparing a patient with neovascular AMD who receives a once-a-month injection versus someone who gets essentially a once every other month injection, less than half the number of total injections as another group in this study period, who do you think is going to have a better visual acuity outcome at the end of that 12-month period? We can all, without even looking at the data, expect that this bevacizumab treated group had better visual acuity. It was a superiority trial, and they did. But does that actually tell us anything about the efficacy of this agent? That's not a fair dosing strategy. It's not a fair comparison. Sure enough, the FDA came back and said, well, first of all, what are the 2 options that the FDA can come back with? The 2 major options are number 1, approval, thumbs up, or something called a complete response letter, a CRL. Really, the rationale as to why this drug was not approved. It could be related to manufacturing, safety, efficacy. In this point, there were considerations regarding manufacturing and maybe most, surprising, but when you look at the totality of the data, maybe not, a lack of substantial evidence, essentially saying, does this actually demonstrate efficacy? So back to the drawing board, here's another clinical study. This was a short study where patients received 2 injections of either the study drug of bevacizumab or standard ranibizumab. And at that 3rd visit, so the day that they would receive their 3rd injection, visual acuity was measured, and the goal was non-inferiority to ranibizumab through that period of time. It didn't meet the pre-specified primary endpoint. There was a difference in visual acuity that favored ranibizumab. So through 12 weeks, there was non-inferiority. So what did they do? All right, well, based on this data, the FDA said again, there is lack of substantial evidence demonstrating that your drug works the way that you expect it to. And the FDA asked for additional data. They submitted additional data, and on December 31st of this year, the FDA, for the third time, sent them back a thumbs down, saying, you need more data. So it is back to the drawing board. Now, I'm a proponent of real development and advances for improvement in patient outcomes, but here's my consideration for the people that we look after. There is an act of Congress in the United States called the Drug Quality and Security Act, passed in 2013. It has a section in it that is called the Compounding Quality Act. In that act, it expressly prohibits a facility from compounding what they determine a copy of one or more approved drugs. Remember, the bevacizumab that is used intravitreally currently is off-label. So if there was an on-label FDA-approved option, that means that compounding pharmacies could no longer compound our current off-label bevacizumab. That's a copy of an approved drug. That means that off-label bevacizumab would effectively go away unless there was a change to this act of Congress. So what does that mean? Well, okay, bevacizumab is described in this 2023 publication as a cost of $90 per injection. If that goes away, the expected thought, if there is an FDA-approved bevacizumab that doesn't currently exist, the expected cost is $900 per injection. Medicare patient responsibility currently is estimated to be $18 per bevacizumab injection. That is anticipated to increase to about $191 per treatment. So again, I am a proponent for new therapies, advances in therapeutics, but also for access. And I worry that if there is an FDA-approved bevacizumab option for intravitreal injection, I worry about the impact on our current bevacizumab that is, I will say, a cost-effective option for individuals. Now, there are retinal biosimilars that you will see more and more frequently utilized by our local retina specialists for ranibizumab, for aflibercept. The goal is to have a less unaffordable, I won't say more affordable, but less unaffordable option of these anti-VEGF agents. Now, these are our first generation agents with a shorter duration, generally every 4 to 8 weeks need a frequency for injection in neovascular AMD. The price is less than the branded counterpart, but if we look at this specific ranibizumab or Lucentis biosimilar, when it was launched, it was still $1,360 per dose. This is not, I'll say, a cost-effective option, but less unaffordable. What else is anticipated in the retina space? There is discussion about an AREDS 3 vitamin. It's not available yet, but beyond the AREDS 2 formulation, incorporating, I say, quote unquote, B vitamins. I don't know exactly, this of course hasn't been announced exactly what this may entail, but based on a 2022 publication, this demonstrated in vitro, so again, in a laboratory setting, that there seemed to be some proposed real synergistic effect of AREDS 2 plus B5, B6, and folate. So could this be what is anticipated to be added to an AREDS update? So something to be determined. Now let's wrap up in looking at advanced dry AMD or geographic atrophy. We know that complement overactivation is implicated in the pathogenesis, not just of late-stage AMD or geographic atrophy, but also in drusen development, drusen formation, and drusen progression. So early. Now we all need our complement system. This is an important part of our innate immune system that does clear abnormal damaged tissues or cells that ultimately leads to cell lysis. Also a very important system related to cancer biology and cancer therapeutics. So I do have a concern when I see progression of systemic complement inhibition with the goal of treatment of retinal pathology. You know, our complement system is necessary. We need it to live. The overall potential, again, potential for systemic adverse effects here, I think may outweigh the potential benefits in treatment. All right. Fundus autofluorescence, dark areas, this dark spot in the macula, this is geographic atrophy. This is central geographic atrophy in this patient's right eye. We've got two little pockets, a multifocal paracentral lesions of geographic atrophy. We can see in this patient's case as drusen goes away, atrophy increases as this patient's disease process progresses. This is the woman with bilateral rhegmatogenous retinal detachment that we saw earlier, and I will tell you, I missed something in her left eye. She progressed really quite quickly in the left eye with OCT markers, so what happened? May of 2024 in the left eye, she had this large drusenoid pigment epithelial detachment, but something that I missed that when you look closely, look at her retinal tissue. She has, she almost has a full thickness macular hole that's here, but her foveal contour looks great. Why is that? Because of this large druse that's present. So when this druse collapsed, what do we see? Effectively a full thickness macular hole with atrophy that's present. We have two complement inhibitors that are FDA approved for slowing disease progression. This is something that our local retina specialists always remind myself and our colleagues of, to make very clear as possible to the patient, regardless of agent, this patient's disease will progress. It will get worse, even with treatment. Their vision will decrease, even with treatment. It is not the injection that harmed the eye, that caused the visual reduction, unless they have a very rare, uncommon, significant, profound adverse effect. But because of the disease process, even with treatment, the disease will change, visual acuity will worsen. And that's something that the goal is to slow down the rate of worsening over time. There is the interesting safety signal of an increased likelihood in the treatment group of development of neovascular AMD in individuals who are receiving complement inhibitors. This may require not just complement inhibition for their geographic atrophy, but also anti-VEGF therapy for new neovascularization. What we understand is that not all geographic atrophy changes at the same rate. What are the features that we want to watch for? Patients who have non-subfoveal GA involvement, especially multifocal lesions, those individual pockets of GA, those are lesions that tend to grow more quickly. Now, the other agent FDA approved is avacincaptad pegol. It intervenes within the complement system at a slightly different location. We do still see an increased risk of choroidal neovascularization versus the sham group. And keep in mind this goal. Now, we're considering, and our retinal specialists are treating these patients at an advanced stage. But could there be benefit for treatment earlier on, even with this same mechanism of action? Now, looking ahead in wrapping up, this is where gene therapy is we're starting in 2026 to anticipate results of early studies utilizing gene therapy products. What's the goal here is to reduce the frequency of administration. Gene therapy may be a once in a lifetime treatment, or maybe a once in every 4 years or 5 years. That is a huge improvement of our second generation agents that require treatment maybe every 8, 10, 12 weeks. There are different strategies that are being investigated and being utilized in these adenoviral-based strategies. There is, if we're talking about RPE65 by allelic mutation, that's where a patient has a genetic mutation, a homozygous mutation, and introducing a wild type gene, specifically with the agent that's approved, subretinally, which is done in an operating room, can increase, again, that true or impact the visual cycle and return the visual cycle close to normalcy. There, again, are also investigations into changing expression cassettes. I think the therapeutic targets are really what's most relevant in the retina space. Targeting, whether it's the complement system, vascular endothelial growth factor, or even neurodegeneration. How can these agents be delivered? Well, subretinally is the most invasive. They can be delivered suprachoroidally based on early evidence, and there are some products that are being investigated for intravitreal injection. What are the advantages, of course, with suprachoroidal or intravitreal? That can be done within an office, not in the operating room. Couple of agents that are moving through trials. The first, I think this is still the most interesting. The study is certainly now fully enrolled. No data anticipated yet, but this is ADVM 022 for the treatment of neovascular AMD. This is a gene therapy product. Now, what this is inserting a coding sequence, complementary DNA, that is intravitreally injected. Now, this DNA replicates in the deep retina, then ultimately produces RNA from DNA and protein. What is the protein that is produced? It is aflibercept. This is a biofactory approach. The retinal tissue and cells producing its own aflibercept. Very interesting. Suprachoroidal approach, early, this is a specific agent being investigated in neovascular AMD and in diabetic retinopathy as an antibody fragment, again, delivered in a slightly different location, the suprachoroidal space. The goal is for overall prolonged drug reservoir versus the suprachoroidal space. Now, one that I bring up that I just added, as there is news that may come a little bit later this year. This is an agent called vorolanib. It is a tyrosine kinase inhibitor. It blocks VEGF receptors within the cell, so it's a slightly different mechanism. In phase 2 studies, it seems that it also inhibits inflammation. So again, center involving diabetic macular edema, there's vascular endothelial growth factor impact, and anti-inflammatory impact. Now, this is not a gene therapy product. This is almost like a bridge, not a once-in-a-lifetime treatment, but not a once every 8-week treatment. This is being investigated for treatment every 6 months, kind of the sweet spot. Now, what's one disadvantage that I potentially see that I would be concerned about if I were a candidate for this therapy? Injection is with a 22 gauge needle. Anti-VEGF injections, generally your retinal surgeons will use a 30, sometimes 32 gauge needle, higher number, thinner needle. There's been data to demonstrate that the bigger the needle, the wider the needle, the larger the bore, the more uncomfortable for the patient. A 22 gauge needle is a fairly large needle. That's generally about the size that's used for standard adult venipuncture. So you get blood work done, usually it's a 22, 23 gauge needle that the medical assistant or nurse will utilize. That's a big needle, but it is only every 6 months, potentially. There are other geographic atrophy therapies that are in early investigation related to gene therapy. So, to wrap up, angiogenesis and exudation are significant causes of vision loss in retinal vascular disease. The targets for therapies are based on the disease pathophysiology. And these treatment modalities and even how we use imaging modalities that we currently have available are still changing and changing quickly. Anti-VEGF is still the mainstay of treatment in retinal pathology, but we now have therapeutics for other disease states, including geographic atrophy, and it's about identifying these patients ideally early and working with a retina specialist who is, again, open to conversation, open to consideration of therapy, and ultimately, again, improving vision-related quality of life. So I thank you very much, Joe and Greg. Always a pleasure to join you and the team of people. Thank you for joining us tonight.
Well, thank you for doing this, Jessica. It was a deep dive Outstanding as always. There is a clinical question that came in. An attendee's mother had severe vision decrease from Syfovre, had an MRI, and had optic nerve atrophy. Is that an expected finding or contraindication?
You know,
Complication?
Just before you answer, let the crowd know here, the audience know that the red circle is up. If they want to start the survey, they can. I just want to have them be aware that that's up, and please now answer the question.
Thanks. You know, a couple things come to mind as possibilities without knowing the case, without knowing the details. You know, I'm being pretty cautious here. But two things that I think about. Number one is the amount of medication that's injected with the two FDA-approved complement inhibitors. So anti-VEGF injections are 0.05 milliliters. The complement inhibitors are double that, 0.1 milliliters. So a couple of things that I do think about as potential risk factors, maybe not in this case, but overall, is there is an increase in intravitreal volume, which drives intraocular pressure upwards. This can be an IOP of 87 millimeters mercury immediately after an injection. Now, two things can happen. This blow to the lamina cribrosa, especially when repeated, can cause glaucomatous optic neuropathy, optic atrophy, glaucomatous optic nerve disease. So is the nerve cupped is always a question. The other concern and consideration is that there can be a pause in perfusion after this dose of any intravitreal agent related to the significant high eye pressure. This is sometimes where a retina specialist will take a quick peek at the retina with BIO immediately after an injection to make sure that the central retinal artery is perfused. My personal experience with anti-VEGF injections, my pressure, I have low-grade inflammation after a complex retinal detachment repair, and I receive bevacizumab every 3 to 4 months. Now, my experience is my pressure generally goes to about 50 millimeters mercury after an injection. When it's that high, I go no light perception for a couple of seconds, and then gradually I see that entoptic phenomenon of the vessels starting to pulse, perfuse, and then gradually as the pressure comes down, my vision comes back. So things that I think about when we talk about optic nerve health related to intravitreal injections of any molecule are what is the impact of that spike in intraocular pressure? Could it pause retinal perfusion? Could it cause glaucomatous damage due to the spike in intraocular pressure? So two considerations that may be relevant to the, I'm sorry to hear about that case.
All right, we're good. You're getting your virtual round of applause. Everybody loves you.
Good night. Thank you all.
And
So
thank you so much for doing it.
I did your polling question because it was which emerging trend. I did it behind the scenes here while that answer was going on. Is the audience most excited about in the next 2 to 5 years? And it's pretty much, I'll display the answer. We didn't announce it, so it's not a high polling. About 30 people, maybe 40 people now have responded, but they're excited about gene therapy and novel drugs. Gene therapy just took the lead at 42%, novel drugs at 35%. Looks like I got a little bit of work here in the photobiomodulation and the therapies within mitochondria because they were 13 and 8%. So I got to do a little work here in getting some of these naturopathic ways and getting some excitement out there. But I do agree the allopathic and naturopathic will probably work together at some point. So, all right. So I'm going to close that poll. And Joe, any last questions?
Nope, we are good.
Okay, Jess, thanks for doing this. That will end the synchronous virtual course, retinal pathology to retinal practice. I think, Jess, you nailed it. You brought in a lot of evidence-based medicine out there is what we like to say, and you brought it right to the clinical practice. We thank you for doing that for us tonight. That will end the CE.